Welcome to this myelodysplastic syndrome, or MDS Phone a Friend series, where you'll have the chance to listen in on your peers discussing common clinical challenges in the management of lower-risk MDS-associated anemia. Check back frequently to tune into episodes in the series that cover topics such as diagnosis and classification of MDS and management of patients with lower-risk MDS who would benefit from an individualized approach to pharmacologic treatment. Today, Dr. Andrew Kuykendall is getting ready to see Ed, a patient with anemia and suspected myelodysplastic syndrome, and has some questions for his colleague, Dr. Robert Ohgami.
Hey, Bob, how are you doing? Sorry to take you away from the microscope. Glad I was finally able to catch you.
I'm glad we're finding some time to connect. What's going on?
So I wanted to run a case by you. So I've got this guy, Ed. He's a 75-year-old man. He's got a history of high blood pressure and coronary artery disease. He was referred by his primary care physician after he came in with fatigue, shortness of breath, and more frequent episodes of chest pain or angina. His physical exam was largely unremarkable, and his labs are pretty normal except for when he looked at his blood counts. His white blood cell count was 1.4, neutrophil count was 700, hemoglobin 8.1, MCV mildly macrocytic, and a platelet count of 105, and his reticulocyte count was 0.5%. I looked at his peripheral smear. It showed reduced red blood cell count, numerous macrocytes, really no other abnormalities that I was able to detect. And after ruling out other causes of anemia, he's not bleeding or anything like that. Bone marrow biopsy was performed last week. But before we discuss Ed's case in general, let me just make sure we're on the same page about low-risk MDS and why I'm concerned about this as a possible diagnosis for Ed. This is something that I often see in patients that are elderly men, such as Ed. Certainly del(5q) MDS, obviously in this low-risk category, often we see that in women, but other low-risk seems to be more predominant in males. And, when I'm thinking about low-risk MDS, any disease is risky to the patient, but low risk for progression to acute myeloid leukemia from this standpoint. But I really worry in these patients that, that they could still have problems with infection, hemorrhage, bleeding, symptoms related to anemia, and more rarely they do progress. Primarily when I see these patients, I worry about anemia and low platelets or thrombocytopenia, and certainly the symptoms that come with that. More often with anemia, we do see fatigue or dyspnea, shortness of breath. With thrombocytopenia, certainly if it's extreme enough, we can see increased bleeding and bruising. But when I'm thinking about treating these folks with low-risk MDS, my focus is really on kind of avoiding or decreasing their red blood cell transfusion dependence if they're already in that standpoint, and really maintaining and optimizing their quality of life. And certainly, if possible, I'd like to delay or avoid progression to a higher risk MDS setting or acute myeloid leukemia. And I know that MDS is heterogeneous in its presentation and certainly its disease course, but I wanted to ask you, what would we expect to see on a bone marrow smear in someone with low-risk MDS?
Yeah, morphology is critical in diagnosing MDS, and what we typically see, or in quite a few of the cases, is dysplasia. It's something that we're looking for, and obviously with your patient, you are looking at the peripheral blood smear to see whether there was morphologic dysplasia. There are two classification systems that we're using right now, and you know this as well, for the diagnosis of MDS, the WHO classification, and then also ICC. And with the WHO classification and the ICC, there's quite a bit of overlap between the diagnostic categories for MDS. First, thinking about the WHO classification, the 2022 classification there. The way we think about it in a broad sense is MDS with defining genetic abnormalities. So it's going to be critical for your patient to have an understanding of what kind of possible mutations or cytogenetic abnormalities he has. And then the other thing is MDS morphologically defined. So we pay attention to morphology. And really, when we're putting together as pathologists, hematopathologists, a diagnosis or possible diagnosis of MDS, we're really looking at 4 pieces of critical data. We're looking at morphology, we're looking at immunophenotype, we're looking at molecular. So a lot of times that's next generation sequencing, because there's a lot of mutations we have to look at in order to actually accurately diagnose MDS or not diagnose MDS. And then the other one is cytogenetics and FISH. And so again, just going back to the WHO classification for approaching myelodysplastic neoplasms. So that's the way the WHO is now calling myelodysplastic syndromes. It's myelodysplastic neoplasms. That there's 2 broad categories again. So MDS with defining genetic abnormalities and MDS that's morphologically defined. And as far as MDS that's lower risk MDSs, the ones that we think about for MDS with defining genetic abnormalities are MDS with low blasts and isolated 5q deletion. And then the other one is MDS with low blasts and SF3B1 mutation. Equivalent kind of diagnoses do exist also in the ICC, and I'll talk about that in a moment. And then again, as I said before, there's MDS morphologically defined in the WHO classification. And the lower risk MDS that we pay attention to there is MDS with low blasts, so less than 5% blasts in the bone marrow. So it's great that your patient got a bone marrow study. And then also less than 2% blasts in the peripheral blood. And it sounds like there weren't any circulating blasts in the blood. So, for now it seems like in the differential, it could be an MDS and a lower risk one. When we think about the ICC classification, which is also very similar to the WHO classification, essentially you can also think about it in a sense as far as 2 broader categories: MDS that's kind of genetically more defined, and then MDS where we're paying a little bit more attention to the morphology and in particular blast counts. And for, again, lower risk MDSs, the categories and diagnostic areas that we pay attention to or entities would be MDS with SF3B1 mutations. Those patients tend to morphologically have in their bone marrow aspirate smears ring sideroblasts. So that's the phenotypic manifestation of that SF3B1 mutation. And then MDS with isolated deletion 5q. And then morphologically, if we're thinking about MDS in other categories, MDS NOS with single lineage dysplasia, or MDS NOS without dysplasia at all, and having certain kind of cytogenetic findings or mutations is another one that can be a little bit more lower risk. But I'm happy to hear a little bit more about what's going on.
You were saying kind of, talking about one of the importance there is looking at cytogenetics or FISH. In addition to looking at morphology and some of these other features, what should I do? Just kind of overall cytogenetics? Should I do something more targeted? Like, how exactly should I approach this? I know when I go to order these things, there's certainly a lot of options, especially with FISH panels. Yeah,
definitely. And I think the best pathway forward is to be a little bit broader and order essentially an MDS FISH panel. A lot of different labs, your own lab, our lab have essentially an MDS FISH panel that you can order that will take care of identifying a lot of the cytogenetic FISH abnormalities that can help you define a case as a certain type of MDS. So that is the best pathway forward, just like I was talking about for what you really want to get on any of your patients is a routine karyotype and in general FISH analysis. So the kind of cytogenetic abnormalities that you may see in your patients are isolated, 5q deletion, 7q deletion, and those tend to be a little bit more worse prognosis. And then, today with the ICC and the WHO, you're going to want to order some sort of molecular testing, and really that in general means next generation sequencing. There are so many different mutations we need to pay attention to nowadays, especially for prognostication and for risk adjusted scoring with the IPSS, it just makes sense to order a next generation sequencing panel where you're going after the key 30 plus genes for defining your MDS patient in the most specific way. And there are certain genes that you really want to pay attention to as far as potentially conferring a higher risk to your patients or that risk of transformation to AML, right? And those would be like P53, as well as MLL is another important gene to really pay attention to there.
Yeah, I guess following up on that, I just had, when I'm doing these NGS panels, is it important to do it from the bone marrow or from the peripheral blood? Does it really matter which one I do it from? Or because some of these patients, either they already had their bone marrow biopsy or it's not going to be scheduled for a few weeks. So just wondering about that.
Yep. You can do them on peripheral blood, but as a hematopathologist, also since we want to see the marrow. So it's ideal to get a marrow urinalysis on the marrow, where you're going to have to evaluate blasts anyway. So even if the patient has to come back in for another tap, it's a good idea to have the studies done on the bone marrow, because there can be quite a bit more of disease burden in the marrow versus the peripheral blood. So it's an unfortunate thing, but that's a part of the job for you.
Yeah, gotcha. Yeah, that makes sense. So I mean, now that I have all this information, let's say I get the NGS panel, cytogenetics, is there a scoring system or a prognostic model that incorporates all these things? Like, what's the most accurate one to use when I'm trying to talk with my patient about what to expect?
Yeah, absolutely. And so for risk stratification, the IPSS is the best approach, and there are different iterations of it. The IPSS is the oldest. IPSS-R is the revised version, and today we have the IPSS-M, or the molecular IPSS, or International Prognostic Scoring System. The IPSS-M incorporates a lot of different pieces of data, morphology, peripheral blood counts, and so when I mean morphology, I mean blast counts in particular. So there are about 31 genes that are important to pay attention to and to sequence in order to get risk stratification of your MDS patient into 6 different kind of lines.
So for Ed, I mean, I'm presuming that he has a diagnosis of low risk MDS, but how does all of this kind of prognostic stuff, you're talking about all this important stuff we can look at to better understand his disease, molecular, cytogenetic, now kind of putting those into prognostic models, how does this impact kind of management of the disease as we know it?
Yeah, well, as you know, this affects the therapeutic approach, right? It affects also understanding how quickly they're going to transform potentially into AML. Also helps to understand, what are the downstream manifestations as far as significant anemia developing over time or other cytopenias. It also affects, from a pathologist perspective, how frequently you're going to want to get bone marrow biopsies to monitor the patient, or other ancillary studies to continue to see how they're potentially progressing.
Gotcha. I mean, I think this is great information for me. So, it sounds like, what I'm taking away from this is that, when you do have this high index of suspicion, like I have for this patient, that he might have low risk MDS, that really important to kind of expedite that referral to a hematologist oncologist so we can kind of make sure we get that accurate diagnosis. But beyond the diagnosis, get the specific subtype of the diagnosis, get the cytogenetic molecular testing done. And it's really important to get this because we know this helps to provide patients with a realistic expected course prognosis. Patients can understand what their likelihood is of having their disease progress over time and what the risks are entailed with their disease. But it also allows us to kind of individualize therapy and improve outcomes for patients based on their specific disease, because I think certainly as new agents emerge that are targeted towards different molecular and risk subgroups, that we can certainly start to individualize care for patients and not treat this as a one-size-fits-all scenario.
Yeah, identifying that specific type of MDS is really helpful, definitely on the pathology side too, because if we do know that this is an MDS with an SF3B1 mutation, we know when the patient comes back, we're going to look for that particular mutation, but then also for certain, again, as we talked about before, phenotypic manifestations, so ring sideroblasts in particular. It just makes it easier to understand what's going on. Is there residual disease? Is there something else changing?
Thanks, Bob. This has been super helpful. Thanks so much.
Oh, absolutely. Feel free to reach out at any point if you have any other questions about your patient.
Awesome. Well, thank you for joining us for this Phone a Friend program. Please remember to take the post-test and fill out the CME evaluation. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com. That's www.exchangecme.com. You can view other low-risk MDS Phone a Friend episodes on the series landing page.